Hello, hello, hello. This is Kenny Perkins, aka your cancer guy. And once again, as I always say, we have another phenomenal guest. Listen, we don't pause on continents or where we locate or where people come from. We do not discriminate because cancer doesn't discriminate. Here, we are traveling with our next guest. She is from Nigeria, okay? But she is here in the US practicing. She is a breast surgeon. She's been doing this for over 20 years. And let me tell you, you can imagine all of the things she has seen. So this is our time to find out and pick her brain so she can drop gems for you that you can utilize on your cancer journey. Again, please help me to bring in our next guest. We're talking to Dr. Oruwari. Please welcome her to All Talk Oncology.
Hello, hello. Thanks for having me.
Dr. Oruwari, thank you so much for being here. And it's a privilege to be able to have you here on our show today.
It's a privilege to be here with you.
Yes. You know, being a breast surgeon, talk to us a little bit about your background. How did you end up in this field, the medical field, and then specifically, this is very specialized. So how did you end up here?
Okay. So that's two specific questions. How did I get into medicine? It's something that I was told by my parents. I've always vocalized that I wanted to do as early as age 3. That's always been my dream, my passion. I wanted to help people. I wanted to be in this sphere. So that's how I got into it. And my parents really made sure that I was positioned in such a way that I was able to achieve my dreams, going to the right schools, studying pre-med, getting into med school. And then once in med school, then it was, all up to me to decide what specialty to go into, because there are so many different things, because I didn't think that far when I thought I wanted to go into medicine. I didn't think about what type of medicine. So once you're in med school, you have to make that decision. And we go through these rotations. And I liked a lot of things, but there were a lot of things I didn't like. But I really fell in love with surgery. And at the time, it's not really something that women were encouraged to go into, especially women that looked like me. But I'm pretty stubborn, and it's what I wanted to do. So I made it my mission to apply and get into a general surgery training, which was not easy at all. But I am testament that it's doable. I made it through. And somewhere towards probably the mid portion of my general surgery residency, I had a patient that I was taking care of from East Africa. She was in this country by herself. She's a young woman in her mid to late 20s who had a very advanced breast cancer, and she had no one. And that just really touched me in unbelievable ways. And I just could not shake her or her story or her diagnosis, and started looking for ways to make breast cancer surgery, my practice. And found two mentors and two women at our local hospitals who practice breast surgery, and they mentored me, and then did a fellowship at Brown. And that's what brought me here.
My goodness. And we are so happy that you are here because we need more surgeons, breast surgeons, especially, you know, it seems like breast cancer is increasing. And and you as a surgeon, are you seeing more and more patients?
I'm seeing a lot of patients. So the incidence itself, it's not increasing. Um, I think it's perceived that way because I think there's just so much more awareness, and a lot of women are going for screening. So what that does is just allows us to see so much more of the breast cancers that are there. So the incidence itself is just about the same, but and we're just seeing so many more of them because people are more aware.
Yes. Well, thank God for the awareness and thank God for people being advocates of this. You know, on
Absolutely.
on an average, Dr. Oruwari, what would you say? How many patients do you see a week, a day, and then per week?
Myself personally, I probably see about 20 to 25 a day in the office. And surgery, I'm in the office 3 days a week, and I'm in the operating room 2 days a week. Surgery days vary. I could do one long surgery, I could do four surgeries. So it just really depends on what I'm doing. And it varies from, am I doing lumpectomies or breast biopsies? Am I doing mastectomies? And those vary. And the length of time for each surgery, of course, is different.
My goodness. When you think about 25 patients per day, that's quite a bit. I always say that to give a perspective to
Yeah,
people. When you've been doing this, Dr. O'Rourke's been doing this for well over 20 years. So when you think about 25 patients per day for 20 plus years, she's seen thousands of people,
I
right?
do see a lot of people. But let's just make it clear to everyone that a breast surgeon is going to see all breast related problems, not just breast cancer.
Mm.
So probably about 30% of those patients I'm seeing have breast cancer. 70% come in because they're concerned, they have breast pain or they have family history or nipple discharge, whatever it is. But there's a good majority of women who come to see me that don't have breast cancer. And I stress that because women think when they're coming in to see a breast cancer surgeon, oh my God, I have cancer. No, there's a good chance you don't have breast cancer. So
Well, thank you so much for clarifying that because that makes a big difference. Especially today, a lot of people, it's a lot of fear. So
a lot of
when you think about only 30%, that helps you really out of the 25 people she sees per day. So helps you to really appreciate those numbers. You know, what would you say looking at through your career and the people that come in to see you, what is something that you would relate to these patients, maybe that they're not receiving or not hearing or not getting as far as education is concerned?
So I do see a lot of women. Breast cancer does occur in men, but it's mostly women. So the thing that I stress to all women is just really taking care of yourself and taking ownership of your health. Because we as women, we tend to be caregivers. We're caregivers in our families, taking care of our parents and taking care of our husbands and children, or partners and children, that we ultimately neglect ourselves. But when the caregiver becomes sick or is incapacitated, the whole family dynamic is going to fall down because there's no one taking care of everybody else. So it's important for women to take care of themselves so that we are able to continue caring for our loved ones.
Wow. That was powerful for sure. Because we don't think about that. Women being the nurturers and the as they say, the king of that household, right? They're the foundation of that and making sure everything stays organized. And
Mhm.
when she gets sick, and then it's like, okay, well, how are everyone else going to maintain?
Exactly.
Yeah. And so with that being the case, recommendations for how does someone take care of themselves? What do you recommend for people that they do?
Okay. So this is taking care of yourself is a lifelong thing. It's not something that starts the day you turn 50 or the day you turn 40. It should be lifelong. As a woman, from the moment you start to menstruate, you should be aware of your body, aware of the changes that your body goes through monthly. If there are any new lumps, bumps, whatever it is on your breast, you need to bring that to the attention of your doctor. So this means learning your breast and learning the normal lumps and bumps, and that's a monthly thing. From the age of 25, all women should undergo what's called a breast cancer risk assessment, which means going into your doctor, your gynecologist, whoever, your gynecologist could refer you to a high-risk clinic to see what your risk for breast cancer is. And it's an online tool that a lot of breast clinics use to calculate a woman's personal risk of developing breast cancer, which plays on several factors: your family history, your reproductive history, your height, your weight, the appearance of your breasts on imaging, just a whole lot of things we put into a program and calculate your risk. Normal risk is about 12%. Anything over 20% is considered high risk. So these are women that we would start screening early, because screening recommendations is to start mammograms at the age of 40. And what that does is it excludes women under 40 who may be high risk. And insurance will not cover your mammograms if you're under 40. But if you had a breast cancer risk assessment and deemed that you are high risk, then we may be able to get you mammography or breast ultrasound or breast MRI. So that's really important. And then also, beyond breast, keeping up with other screening, pap smears, colonoscopies from the age of 40, 45, getting blood pressure and blood sugar checks. Just these are all things that we don't think about because we feel well. And it's just important to stay on top of this because you don't want to wait till you're sick. You want to practice preventative medicine, and that's what all of this does. It's just prevention, or so in breast cancer we say risk reduction because we don't really like the word prevention, but risk reduction. So those are the things that I would recommend for women to be doing.
Yes. I hope you heard these gems, everyone out here that's listening, because you want to reduce those risk factors. And see, these are some of the things that you have control over and that you can utilize as a tool to help you. And as a radiation therapist myself, I'm seeing young women come in with breast cancer and that's receiving treatments. And so if you listen to what the doctor just talked about, you want to make sure you get those tests taken care of and find out where you're at, because if you are high risk, like she said, you want to get that taken care of. Great. Thank you so much for educating us on that.
Absolutely.
Yes. I can only imagine, how do you balance, this is a personal question really now. It's like, how do you balance your work and what you're doing, and also just with your own life? That sometimes there's an imbalance. So how do you do that?
I'm a super balancer. I would probably win an Olympic medal in balancing because balance is very important to me, because what I do on a day-to-day basis is very heavy. And I don't want it to consume my life, because if I take each one of my patient stories home with me, I'm not going to be able to function. And that's not acceptable, because I am a wife, I am a mom, and I need to be present for my family. I need to be present for my friends. So I make it a priority to self-care. I make time I have date nights with my husband. When the kids were home, they're older now, we had time that we spent with the kids. I have time with my friends, and I have dinners with my friends. I have dinner clubs, book clubs, all sorts of clubs. We're out all the time. And these things are all important to me because they are part of who I am, and it keeps me sane, it keeps me grounded, and it gives me energy to keep caring for my patients.
Yes. Thank you so much for that. I love that. Because sometimes all of us, we look at those in the healthcare profession as these superheroes, and we come through. And so it's nice to see the human side of that. And we need to keep ourselves balanced and, and live a life, live life like everyone else.
Most definitely.
Yeah.
You have to keep up your interest. That's what when I talk to medical students that I mentor, that's what I stress to them also. You have to maintain your interest before med school. If you were a movie buff and you love to go to the movies all the time, keep doing that. If you're a runner, keep doing. If you love to be in the gym and exercise, make sure you do that. If you love to cook, make time to do those things, because that's what's going to keep you sane at the end of the day, because medicine can be all consuming and you don't want it to consume you.
Yes. Yes. You know, Dr. Oruwari, I'm going to ask this question. You and I being of color, what do you say? How do we bring more awareness in the communities? One, we talked about there's more awareness overall in general, but how about in the communities um, where there's minority communities? How do you bring more awareness in that?
So, what I do currently in my practice, and I transitioned about 4 years ago from a practice that was in suburban St. Louis to one that was in kind of in the lower income African American community. And in my role in the hospital, part of what I do is we are out in the community. I think we as healthcare providers have to be actually out in the community doing things. We can't just sit in the office and talk the talk. So I go to churches and I give talks. I go to community events and I give talks. I have a walk that I do monthly with the community. We meet at a park and we walk for an hour, and gives me an opportunity to engage with people at on a one-on-one basis, one-to-one basis, where we talk about all sorts of things, medicine, non-medicine. So I think the community needs to see you and trust you and know that you're available for those questions. Otherwise, it's a lot of mistrust. And this goes back to, years of, we know Tuskegee experimentation, Henrietta Leaks, all of that. I'm not going to rehash all that, but there's a lot of mistrust. And we need to gently rebuild that trust. And part of it is being out in the community.
Absolutely. Absolutely. And those feelings run deep. And so when you talk about that, it is a process, but it's refreshing when we see someone like you, Dr. Oruwari, that's giving back and in a position that where you can trust. So thank you for that.
Of course.
Yeah. You know, looking at the advancements and the things that direction the cancer is going in right now, what is your thoughts on just being better proactive?
You mean in terms of someone being proactive, or in terms of medicine being proactive? I just
Me-
want
I,
to.
yes, I apologize for that.
No, that's okay.
And medicine being proactive.
Okay. So, I mean, there has been a lot of advances over the past, even in the past 20 years that I've been in practice. A lot of things that we did 20 years ago, we're no longer doing. We've learned some things. We learned ways to do things better, and I think it's only going to continue. So for me, it's important to keep up with all these advances, because then I can bring it to my patients so that we can be better prepared for what's coming or what's to come. So being proactive involves lifelong learning, I think.
Yeah.
And that's what medicine is all about.
Yes. We always talk about the continuing educations, right? In
Yeah.
our in
Mm-hmm.
our field. Those that don't know what that is, it's just you're always constantly staying on top of what's happening in the
Mm-hmm.
industry in your field. So that's what Dr. O'Reilly is talking about. Thank you for that, Dr. O'Reilly. That's
Right.
important.
And even in what you do, I remember 20 years ago, radiation was 6 weeks every day, Monday through Friday. Today, most women can be done with radiation in a week, 2 weeks. And that's such a huge difference. And Yeah, I mean, it's amazing what we've done and how far we've come, and I'm really excited for what's to come.
Absolutely. Absolutely. And just to give you, if you've been diagnosed with breast cancer, it depends. Would you say, Dr. O'Rourke, on what your staging is? Because some people get what is called a mammocyte or the savvy in placed, and are those things that you implement, right?
Yes, we're not doing too much of that anymore. We did a few years ago,
Okay.
but now you can receive standard radiation in a short period of time, where we don't really need to do the savvy or the mammocyte. But yes, a lot of people still do it, which is
Yeah.
fine. Yeah, it's just there are options. We have options today.
Options.
Yeah.
And if you guys don't know what we're talking about, we're Savvy and Mammocyte. It's a device that gets implemented into the breast surgically, and that's what Dr. O'Rourke was talking
Right.
about. That's what
Yeah.
she's talking about. It's not so much. It's not done so much anymore, but those are options that you can have. And then
Mhm.
she was also mentioning that we've reduced the amount of time we're doing radiation for breast treatments, because before we used to do 25 to 28 treatments, and now they've been reduced to almost 16 or less, right?
Mhm. Right.
Yeah.
Right.
That's
It's amazing actually. Mhm.
phenomenal. Phenomenal. Now, I'm not going to let you off the hook, Dr. O'Rourke, because you are worked on some amazing things. If you guys don't know, Dr. O'Rourke has her own book, right? Black Girls in White Coats. Could you tell us a little bit more about your book that you wrote there?
I am happy to do that. Yes. So this book was born during the pandemic when, we had a little bit of downtime. And that was just about when I transitioned from suburban practice to inner city practice. And what I noticed at the time was, this is when there was so much conversation about the vaccine. Should we get the vaccine? Should we not get the vaccine? Is it safe? Is it not safe? And my patients in the inner cities were not having it because, what are you guys trying to inject in me? It's not safe. You're trying to put a chip in me. It's experimentation, da da da. And in that year, I think I spent more time talking about the vaccine than about breast cancer. I would sit down with a person in the office for about 30 minutes, and my conversion rate was 100%. Everybody I talked to about getting the vaccine and convinced them to get it because I've gotten it, my husband and my kids did, it's safe. They did. So I started to analyze why this was. And my husband did the same because he's a psychiatrist and he had the same conversion rate. And some of my other friends that were physicians did also. And the common denominator is that we were physicians of color. And started to realize that people that look like me were more likely to listen to the medical advice that I had to give. So there's a lot of value in what I had to say as a person of color to people of color. And started doing more research, and which I didn't know before, but Black women make up about 2% or less of the physician workforce in this country, which is 2%. Like, that is ridiculous. So I found 60 physicians of color, women all across the country, different specialties, because I had this idea about a book to talk about what drove them into the medical field, like the questions you asked me at the beginning of this podcast. What keeps them going every day? What were their highs, their lows? Why would they encourage a woman of color to go into medicine? Would they do this again if they had to? And this was how the book was born. And the book is intended for grade school, middle school, high school girls of color who are interested in medicine or even who are not interested in medicine, because the idea is to plant that seed and encourage them, because I'm not going to practice forever. And when I retire, I would like to know that there are other people coming behind me taking care of people. So the book is on Amazon. It's called Black Girls in White Coats. It's also on my website, drjovitaoruwari.com. And I feel it's a phenomenal book. I don't think there's any book like that out there. And just hearing these women's stories is just, you'd have to look at it and see, but I'm biased. So
I love it. I love it. Listen, if you guys are out there listening in, if you want to be inspired, if you are a woman of color and you want to see inspiration at its finest, make sure you go out and get that book. Okay. You already know where you can get it. Amazon or Dr. Oruwari's website. Okay. We're going to make sure we put the links and things like that so you guys have access to it. Dr. Ward, thank you so much for giving back. Thank you so much for giving me some of your time and my listeners. It was a privilege having you on here. But
thank you so much.
Yes. But before we let you go,
oh boy.
Is there anything you would like to say to the listeners that are tuning in today that they can benefit from? that they can benefit from?
Absolutely. Mammogram screening is so important. It's the standard. Start getting your mammograms at the age of 40 and yearly. Don't skip years. Do them every single year. If you're under 40, especially if you have a family history, please get a breast cancer risk assessment to see if we can get you started with your screenings earlier than 40. This could potentially save your life. That's all I got.
Thank you. Thank you so much, Dr. Ward. It's a powerful statement. And I hope you guys are taking that in. Dr. Ward, it was a privilege having you on our show. And please don't be a stranger.
I will not be. Thank you so much for having me. It's been a lovely discussion.
Absolutely. And to all those listening in, here's where you'll find updated discussions on All Talk Oncology. And remember, as I always say, you're not alone in this. We're in this together. This is Kenny Perkins, aka your cancer guy. And until again, I'm out.
So stay connected with us on All Talk Oncology Cancer Podcast. Make sure you subscribe to that, right? Wherever you listen to your podcast, whether that's Apple, Spotify, make sure you subscribe and continue to spread that word, right? Engage in this because your engagement can help someone stay alive. And this is what we're talking about. So again, make sure you subscribe, hit that subscribe button. Again, this is Kenny Perkins, aka your cancer guy. Until again, I'm out.